I wanted to share my data of about 100 patients in which we had done ocular surface analysis. And this is the equipment that we were using. It's a SBM ocular surface analyzer. And we are well aware that there are 3 layers to the tear film: the lipid layer, the aqueous layer, and the mucus layer over the corneal and conjunctival epithelium. And each layer has a function. The lipid layer prevents the tear film evaporation. The aqueous layer contains the water and the nutrients to nourish and protect the cornea. And the mucin layer adheres the tears to the eye. And this is how the machine measures the tear breakup time. It's a non-invasive technique using the Placido rings. And each time the patient blinks and then stops, the machine analyzes when the tear film starts to break. And this is how the lipid layer would look, the rainbow colored layer that is over the cornea. The thickness is also measured by the machine, and it also measures or calculates the loss in the meibomian glands, the upper lid and the lower lid. And this is how it pictures and quantifies whether the meibomian gland is healthy or unhealthy or lost. And the machine also has a software that it gives a treatment guidelines, what needs to be done in which patient, whether it is warm compresses or antibiotic ointments or steroids or tear substitutes, and also the dietary supplement or even the radio frequency, whether the patient needs or not. So this is what the meibomian gland would look like. The normal is here. Do you have a pointer? Anyway. So in the middle you have moderate loss, and here you can see severe loss. So this is what a severe loss would look like. This is what a severe loss of meibomian gland would look like in the machine. And the machine, this is where the calculation is, the red and the yellow and the green. So in our 100 patients, this was the sex ratio, lesser number of females as compared to males. And the age distribution, as you can see here, it is the problems with dry eye are more in the working population and lesser in the age groups where we would expect more dry eye to be there. And in the tear breakup time, we had more patients with early tear breakup time as compared to the normal. Tear films normal would be anywhere between 15 and above. If it is less than 15, then there's a problem with the tear breakup time. As regards the lipid layer, the machine marks from A, B, C, D. 0 is very less number, but A is the least tear lipid layer thickness, then B is little more, C and D is normal. So most of our patients were in A or B. As regards the tear meniscus, the height of the tear meniscus, right and left eye, most of the patients had a good height of the tear meniscus. As regards loss, again, most of our patients did not have much of meibomian gland loss in the upper lid or the lower lid. So what we concluded was that it is the lipid layer which is deficient in majority of the patients. Meibomian gland loss is more seen in the upper lid than in the lower lid, And tear meniscus is good in majority of the patients. And this is slightly different from Western literature, where tear meniscus has been found to be deficient in most patients, and you are well aware that we have all the tear substitutes that we have target the tear film, the aqueous layer of the tear film, and not the lipid layer. And what we found is that the mixed type of dry eye was more common, and as yet we do not have any lipid replenishing drops, which was the cause of the dry eye in majority of our patients. We are only giving aqueous replenishing drops, and MGD disease was very common, which needs both antimicrobial and anti-inflammatory agents, and many of our patients do not benefit by just giving the aqueous replenishing drops. And the one drug that has recently come from Alcon, they say that it is going to replenish the lipid layer, but in practice, we had very few patients who have said that yes, this drop has actually made a difference to their symptoms of dry eye. The ocular surface analysis needs a trained technician. It can't be done by anybody. It takes time. It is not patient friendly because you have to evert the lids, the upper lid and the lower lid. And that is why in my practice what I do is that we are offering this test only if the patient has had symptoms of dry eye for a long duration, or if the patient has been shopping from one doctor to the other with symptoms of dry eye. We don't routinely do it in all patients who come with symptoms of dry eye to our clinic.